and welcome my viewers. This is a new episode of our program Spotlight on Medical News. We try always in each episode to catch from different specialities the most recent medical news that had been recently downloaded on our medical website www.mohp.government.eg. Today's episode is going to be from the branch of hepatic surgery, talking on liver tumors, how far its incidence become so important to be researched, and how can we manage these cases. That's what we're going to know from our discussion with today's guest for this episode. I'd like to welcome Professor Dr. Alaa Ismail, Professor of Hepatic Surgery at Ainshams University, and he is the head of the Hepatology Tropical Medicine Research Institute. Welcome, Doctor.
You are welcome here.
Talking first about liver tumor in general and how far we can evaluate the incidence of this disease in Egypt.
You know that liver tumor is one of the complications of hepatic cirrhosis. And as you know, liver cirrhosis is a sequelae of hepatitis infection. As you know that hepatitis either B or C or other types of hepatitis can be complicated by liver tumors. These liver tumors cannot happen for all patients suffering for hepatitis, but the incidence is no more than 2% of cases. And the duration of the disease no more than or not less than 20 to 30 years suffering of the disease itself, then the development of malignancy can happen in no more than 2% of patients.
So we can say that this is a little incidence which cannot be considered.
It is a little incidence, but you know that because of the high incidence of the hepatitis, either B or C in our country, so the incidence appears to be high, but it is not like that. And now we are suffering from a bigger number of patients suffering from liver tumors, because you know that we started to feel the hepatitis either B or C in our country about 25 to 30 years before. And this is now the era of the complications. That's why the number of patients we see now in our clinics, in our hospitals, in our institutes is a bigger number.
So we can say that although hepatitis is one of the diseases that its manifestation can be discovered after 10 years after the infection of the patient, but its complication is one of the most important complications is the incidence of liver tumor.
Yes, liver tumor, one of the complications of hepatitis, and you know that there are many complications for hepatitis if it is complicated by cirrhosis. Not all patients having the infection by hepatitis, either B or C, are complicated by so many complications. But you know that if we have 100 patients having the infection by hepatitis, either B or C, 20% of them can be cured spontaneously by the compensatory mechanism of the body itself. And the 80%, half of them go into chronic hepatitis, and 2% of these go into complication.
So it's not mandatory for every patient got infected by hepatitis to have liver tumor?
Yes, because every patient having the antibodies and the antigen of hepatitis will be so afraid that he is going to be complicated by all these complications. But it is not the fact that all patients having this complication.
Professor Dr. Alaa Ismail, what about the pathogenesis and pathological changes that takes place in the liver to get this tumor?
You know that cirrhosis is the target which can induce inflammatory process, and this inflammatory process can lead to malignant changes. We are now looking for the exact pathogenesis, and we are doing our research doing the about what genotype of the virus which can induce the malignancy, and is it reflect the genotype of the virus or the genotype of the patient, the host itself. And we are looking to reach a proper conclusion about the exact pathogenesis by doing some researches in our institute about the exact pathogenesis to detect early who is the patient is going to develop malignancy in the early stages. This is a part of our research, and we are doing that, and hardly we are looking forward to reach our conclusion. This piece of work is done in collaboration between our center and other centers in the United States.
And the tools for early detection of pathological changes of liver tumors are by taking biopsy, making ultrasound, or what are the methods of investigations that help to get these results?
You know that we are looking to detect any changes very early, because very early detection of the disease can lead to a proper and good prognostic value after treatment. So any patient having hepatitis should be followed up by his physician by doing alpha-fetoprotein and ultrasound every 3 months. And if the alpha-fetoprotein is rising with every session of visit, we have to put our patient under strict supervision, because there should be something which is developing inside his liver. You know that cirrhosis itself increases the alpha-fetoprotein, but it is not to a higher level. So a level of alpha-fetoprotein above 500 is an indication of developing of focal lesion. This focal lesion can be detected also by ultrasound. So if there is a focal lesion detected by ultrasound and the patient is cirrhotic and the alpha-fetoprotein is high, so we have to complete our investigation by doing CT, spiral scan, and to detect the site and the size of the tumor, and immediately go for plan of management of this patient.
And of course, because this is the era of surgery and surgical operations, the new technology and the process of transplantation, liver transplantations had become one of the most important cornerstones in the tools of management of hepatic patients, whether they are pathological changes of the liver is due to tumor or due to any other disease. Still, liver transplantation actually is the main line of management for liver tumor?
Yes, but there should be some restriction. If a patient having cirrhosis and end-stage liver cirrhosis with a liver tumor, it should be no more than 5 centimeters, and the portal vein is patent, and there is no other satellites, and there is no metastasis anywhere. So liver tumor can be transplanted in respect of the size of the tumor, and no portal vein thrombosis, and no other metastatic lesions.
This means that there are still other trials or still other ways of management for the cases of liver tumor?
Yes, liver tumor can be managed not only by the surgeon, but there is a consultation by group of physician or group of specialties. It includes a liver surgeon, hepatologist, and radiologist. They have to meet and to discuss the condition of the patient, to look for the size, the site of the tumor, the condition of the patient, the condition of the liver, and the condition of the other organs of the body, to exact the way of management of such a patient.
And surgical removal of sizable tumors, how far can we follow the patients after removal of these tumors in order to prevent or to early detect the appearance of other sizable tumors?
You know, surgery or surgical removal of the liver tumor is the best way for managing the liver tumors. And you know that after resecting the liver tumor, there is no need for chemotherapy or radiotherapy or other modalities of treatment. But if we have more than a focal lesion in the liver, we can go to resect the bigger one, and we can ablate the others by other modalities, either by radiofrequency or by alcohol injection. If we have a sizable tumor, we can start by chemoembolization. And this chemoembolization can minimize the size of the tumor, and to minimize the size of the tumor, we give the chance of the other part of the liver to grow. So this will increase the reserve function of the liver. At that time, we can complete our treatment either by ablation of this tumor if it becomes smaller in size, this ablation either by radiofrequency or alcohol injection, or by resection, if the condition of the patient, condition of the liver, can allow the surgeon to go for resection.
To follow the condition of the patients and follow the prognosis of the case by alpha-fetoprotein, by CT scan, by sonar, we can follow this prognosis?
Yes, you know that our patient should be followed after surgery by alpha-fetoprotein and routine ultrasound. This is to follow up if there is recurrence or not. You know that the etiological factor is still present. We are treating patients with two diseases, the liver cirrhosis and the tumor on top. So we are treating two diseases, the cirrhosis and liver tumor. So the etiological factor is still present. We remove the tumor itself, but what induced the liver is still present. So we have to follow our patient for fear of recurrence of or new focal lesion.
After the surgical management of patients with liver tumors, can we expect the life expectancy or the survival rate for these patients after doing this operation?
The survival rate depends on the reserve function of the liver itself. It is not due to the surgery or removal of the tumor itself. It depends on the condition of the liver and the degree of cirrhosis of the liver and how this cirrhosis is so advanced or so early. If it is so early, the patient can survive for a longer period of time, more than 5 years. If it is so advanced, the patient will die from complication of cirrhosis and not complication of the tumor itself.
Well, Dr. Alaa, I'd like to thank you very much.
Thank you very much.
Well, my viewers, that was all about this episode of our program talking about liver tumors, what's new in the incidence of these cases, how can we control it, how can we manage these cases, what about the new surgical lines of treatments. That's what we know from our guests for today's episode. Thanks for watching us and wait for a new subject and new spotlight on Medical News.